Good day, everyone, once again, and welcome to Pattern Nigeria. Once again, my name is Dr. Chinyere Elena Ekanem, and I'll be your moderator for today's session. Pattern is a quarterly webinar series within the Pattern Network designed to present real-life clinical cases, foster peer engagement, provide access to experts, and share practical lessons for frontline healthcare providers. So we look at the realities healthcare workers encounter during clinical care. The objective of this webinar is to provide a platform for case-based practical learning aimed at improving HIV service delivery for pregnant and breastfeeding women, children, and adolescents across our facilities in Delta and Adamawa states. Today, we would explore experiences and challenges faced by healthcare providers in terms of case finding and HIV testing, ART initiation, retention of children and adolescents in care, supporting adherence to achieve viral load suppression and optimal health outcome. So during this webinar, healthcare providers will present real cases, followed by a panel of clinical experts who will provide insight, recommendation, and expert guidance. So for our first case presenter, we have Dr. Michael Moemeka. Dr. Michael Moemeka is a public health and HIV program specialist with an extensive experience across pediatric, adolescents, and adult HIV service delivery. He works with PATA supporting initiative that strengthens learning system, improves service integration, and enhance outcome for children and adolescents living with HIV. He plays a key role in advancing vertical transmission prevention through strengthening HIV, hepatitis B, and syphilis retesting, and integrating maternal and child health services in Delta State. His work focuses on implementation science, health system strengthening, and sustainable HIV program delivery. Dr. Michael Mermeka, you have the floor.
Good morning. Welcome everybody to this part of your presentation today. It's always a pleasure to have healthcare workers to team up and to gather and to meet to share their experiences on how to care for HIV clients. Today, I'll be presenting client, 25-year-old Nigerian female, who presented for ANC at 22 weeks, 6 days. She's unmarried, has limited social support and her family, except for my immediate family. There were no reported disclosure concerns. Her partner's HIV status was unknown, and the engagement in care was not established at the time when she presented. She lacks a reliable residential address and formal identification, with significantly complicated follow-up and patient tracking efforts. Although her exact socioeconomic status could not be formally accessed, her history of prolonged disengagement from care suggests some underlying psychosocial and economic vulnerability. Her level of health literacy appears suboptimal, particularly regarding the importance of continuous care in the HIV program. She has one previous child who is 5 years old and is HIV positive. Excellent. Despite prolonged interruption in care, the client did not present with overt opportunistic infections or advanced HIV disease. This may be explained by individual variability in disease progression, possible partial immune preservation, and absence of documented comorbidities or co-infections. However, this does not negate the risk of high risk of HIV viral rebound and transmission, as evidenced by her first child's positive status. In the current pregnancy, she booked in late, as I explained, 22 weeks. Her physical examination findings were unremarkable. SFH was consistent with the gestational age, and there was no opportunistic infections and comorbidities. Next slide, please. Yeah, baseline clinical parameters were stable. She weighed 61 kg, height 165, her BMI was 22. Blood pressure was normal. ANC investigation carried out, including mental health screening and counseling conducted, and there was no abnormalities detected. Next slide. Okay, so this is her viral load history. From the care card, we pull out all this data. We'll be going forward and back, making reference to this slide. Her viral load when she presented in October 2023 was not done. That was when she was initiated in care. Her post-EAC viral load was done 3 months later, which was, she now showed suppression less than 20 copies per meals. Post-delivery was suppressed as well, based on, that was based on adherence and paraviral. The subsequent routine viral loads that were done in October 2024 and 2025 were suppressed. Next slide. The client was initially diagnosed with HIV during her first pregnancy at age 19. She was commenced on TLD regimen, but subsequently lost to follow-up for approximately 5 years. During this period of disengagement from care, she relied on herbal remedies and did not receive any ART therapy during that period. She re-engaged in care on October 2023 during her second pregnancy. Next slide. Following re-engagement in care, the client received comprehensive integrated ANC and HIV services. Like I said, she was reinitiated on TLD. Although resistance testing was not performed due to programmatic limitation, the decision to restart DTG-based regimen was based on its high genetic barrier to resistance and WHO recommendation used in re-engagement scenarios. Close monitoring of her viral load, as shown in the previous slide, served as proxy for treatment effectiveness. Utrimoxazole prophylaxis was also initiated as part of national treatment guidelines. Next slide. Okay. She was enrolled into a structured follow-up with intensified adherence counseling and support, what we call EAC here. During the EAC sessions, the root cause of the interruption in treatment were identified and addressed, some of which were her poor health literacy, belief in herbal treatment, some of the weak follow-up systems that we have in the facility, and lack of stable contact information. Now, this targeted counseling and continuous engagement resulted in the client's improved understanding and adherence. She completed EAC 1, 2, and 3 subsequently. Labor was uneventful with no reported complications, and delivery occurred at term. There was no documented post-delivery sequelae. Despite maternal viral load suppression, the infant was placed on dual prophylaxis, likely due to the team's perception of her long history of ART interruption and prior vertical transmission that she had with her first child and late ANC booking. Attempts were made to reach out to the partner. So partner testing and involvement was suboptimal because the partner was unavailable. This represented the missed opportunity for index testing and support. Next slide. Okay, EID, early infant diagnosis services was also given to the child. Immunization services, infant feeding, counseling, tuberculosis screening for the mother, malaria prevention and treatment, and ongoing psychosocial support. Postpartum contraceptive counseling was provided to support reproductive planning and prevent unintended pregnancies. These interventions resulted in sustained maternal suppression and a successful PMT outcome, with the infant testing HIV negative after 18 months each. The client subsequently developed a strong relationship with the case management team, which facilitated trust and consistent engagement, improved communication, ability to access HIV care, even when traveling or relocating to different environments. Now, this highlights the importance of patient-centered continuous care models, which is what we practice here in the facility. Next slide. Okay, the challenges we had during the management of this patient. First was no reliable address or identification documents, preventing the tracking, linkage, and retention team from being able to locate her address, and this caused the treatment interruption. Prolonged loss to follow-up. She defaulted from care for 5 years, leading to a risk of high viral load, poor maternal health outcomes, and HIV transmission to the first child. Reliance on herbal medication. Some cultural beliefs here feel that herbal medications are more superior to Western medication. Poor understanding of HIV care contributed to treatment interruption. And she also lacked the awareness of the risk associated with missed visits and poor adherence. Facility level efforts to trace her were unsuccessful due to some structural gaps in patient tracking in the facility. So the lessons we learned, early and persistent counseling on the importance of ANC visits, ART adherence, and PMCT is essential to prevent prolonged interruption in care. Engaging local structures such as community health volunteers, PM mothers, traditional leaders, civil society organizations can improve follow-up for patients with poor documentation. Partner and facility partners can support the development of improved patient identification methods and linkage systems, especially for mobile and undocumented clients, as this was seen in our client here. Addressing psychosocial needs, stigma, cultural perceptions of herbal treatment, and socioeconomic barriers improves maternal retention in care. Despite the long interruption in care, re-engagement with EAC, that's enhanced counseling, adherence counseling, and close follow-up with viral resulted in viral load suppression and prevented HIV transmission to the second child. Next slide, please. So in conclusion, this case demonstrates that successful PMCT outcomes are achievable even in high-risk scenarios, provided that re-engagement strategies, adherence support, and integrated maternal child health services are effectively implemented with clients. Next slide. So one of the questions we have for our panelists is, how can we support facilities in addressing identification and migration-related challenges, such as incomplete documentation, that hinder effective tracing in these clients? Thank you very much. That's the last slide. Next slide. Next slide. Thank you very much.
Yeah, thank you. Thank you, Dr. Omoemeka, for this insightful presentation. At this point, we would like to open the floor for questions and reflections from the participants. You can please share your questions in the chat box. So our next presenter is Mr. Gabriel Onguga. Mr. Onguga is a skilled statistician and data specialist with a strong experience in health data management, statistical analysis, and research support within the public health space. He holds an MSc in statistics at Modibo Adamawa University, Yola, and currently serves as a data assistant with Achieving Health Nigeria initiative. He plays a key role in driving data reporting, analysis, and evidence-based decision-making. He is passionate about strengthening health information systems through accurate and timely data insight. And he has also contributed to several publications. Mr. Onguga, please share your experience.
Right. Good afternoon and welcome to this case scenario presentation at Yola Specialist Hospital, Adamawa State. My name is Gabriel Onguga. Clinical history and family circumstances of our case scenario. So the client's name is Zion Collins, a 17-year-old Nigerian adolescent male who was diagnosed with HIV infection at the age of 14 years. This indicates that he has been living with HIV throughout his adolescent formative period or years, a stage often associated with challenges in treatment adherence, psychosocial adjustment, and transition to self-management of care. The client's mother was diagnosed with HIV infection during her first ANC visit. However, she struggled to accept her HIV status and remained in denial, which resulted in her refusal to access HIV treatment and prevention services. Consequently, she delivered the child at home without skilled medical assistance, and the infant did not receive prevention of mother-to-child transmission interventions. The mother later died from HIV-related illness while still in a state of denial about her condition. This sequence of events increased the risk of vertical transmission of HIV to the child. The client is the youngest child in a family of 2 children. His elder sibling, the first son in the family, is HIV negative, and the father is also HIV negative. This family health profile suggests that the client's HIV infection most likely resulted from mother-to-child transmission during pregnancy, delivery, or breastfeeding. The client's father is a gospel preacher by profession and leads a pastoral ministry, a role that often requires him to travel and spend extended period away from home. As a result, his availability to provide assistance, consistent care, supervisions, and emotional support to the children has been limited, particularly following the death of the mother. This situation contributed to caregiving challenges within the household. So following the death of the mother, the HIV positive child was taken into the care of neighbor's aunt. While this caregiving arrangement provided immediate support and ensured the child was not left without care, it lacked a structured and coordinated approach to HIV care and inconsistent supervision, formal caregiving responsibility, and systemic adherence support. Next slide. Diagnosis. The patient developed persistent illness, which leads to hospitalization in February 2023. A subsequent clinical investigation and laboratory test confirmed HIV positive status and was initiated on ART on 20th February 2023 with adult first-line regimen of TDF, 3TC, and BTG. However, adherence to medication has been poor due to multiple interrelated factors. This includes non-disclosure of HIV status, forgetfulness, and the absence of a stable caregiver, as the only surviving parent, which is the father, is frequently away. Additionally, the parents experience a high P burden. The patient, of course, they experience a high P burden and lacks treatment support at home, being the only individual on ART in the household. Again, emotional instability further complicates adherence, as regular access to adequate meal is inconsistent due to the father's care and social instability. Moreover, the is subjected to pressure from the fathers regarding career choice, which may contribute to emotional stress and further affect treatment adherence. These factors collectively are consistent medications use and effective management of the condition. Next slide. Clinical presentation. The patient presented with a persistent cough and oral candidiasis. Tuberculosis was ruled out through negative Genexpert and TB. Immunologically, the patient was compromised with a CD4 count of less than 200 cells per ml, indicating advanced HIV disease. Despite this, screening for hepatitis B virus was negative. At presentation level, the weight 46 kg, had a height of 150 centimeters and a body mass index of 20, suggesting a relatively normal nutritional status despite underlying health challenges. The patient was maintained on the adult first-line regimen ART throughout the period under review. Viral load monitoring showed persistent unsuppressed levels initially, with 2,800 copies per day recorded in September 2023, which increased to 4,250 copies by March 2024. Following this, a significant spike to 297,327 copies per day was observed in March 2025, indicating poor adherence or treatment failure. ESC was initiated after the first unsuppressed result to address these challenges. Next slide. The continuation of that. The patient was initiated on ESC immediately, consisting of 3 consecutive sessions. Following the completion of this session, a post-ESC viral load test was conducted, which indicated that the viral loads remained unsuppressed. In response to the last unsuppressed result, the client was enrolled in ESC for 3 consecutive sessions, followed by an extended period for 2 additional months. Full disclosure of HIV status was also conducted during this period. This intervention resulted in marked improvement in treatment adherence and clinical outcomes, as evidenced by viral suppression to 20 copies per day in September 2025, which was sustained in February 2026 with the same copy.
I think we've lost him. Mr. Gabriel, are you there?
Yeah, I think so.
I think so. We've lost him.
Okay, sir.
Is
Doctor,
anyone
Yeah,
there with this?
Can you hear me? Yes, I lost the network. Very brief. Can you hear me now?
Yeah, we can
Yes.
hear you now.
Yeah,
All
we
right,
can
thank
hear
you so much. Yes, thank you so much for. I'm sorry for that network interruption. So this indicates that adherence intervention were effective, leading to successful viral suppression and improved clinical stability. The extension of the ESC period was necessitated by the observation that the client did not adhere to medication despite follow-up phone calls. Consequently, the client was invited to visit the facility where he presented in person and received additional counseling. This intervention led to the decision to extend the ESC period. And next slide. So, in addition, a comprehensive adherence support plan was implemented to address the patient's challenge. This includes weekly adherence reinforcement phone calls to ensure consistent medication use. The patient also received full disclosure and post-disclosure support facilitated by ESC focal person, with active involvement of the aunt during clinical visits to strengthen adherence at the household level. Further support was also provided through community-based ESC involving weekly home visits to monitor progress and offer guidance. Adherence was reinforced through routine pill counts and the use of medication allowance to minimize forgetfulness. The patients also benefited from mental health and psychosocial support alongside continuous disclosure support to enhance understanding and acceptance of the condition. In addition, career-related counseling and guidance were offered to address external pressure and improve overall well-being. The patient was also enrolled in the OTZ program to provide structured adherence, focused adherence, and retention support. Next slide. Okay. Outcomes and lesson learned. This case reviewed key challenges and important lessons regarding the patient's care and treatment outcomes. A major challenge identified was the absence of a dedicated caregiver, coupled with no disclosure of the patient's HIV status. This lack of support and openness contributes to poor adherence to treatment, resulting in unsuppressed viral load. From this situation, important lessons were drawn. It becomes evident that parental denial of a child's HIV status, along with inadequate commitment and support from caregivers, can negatively affect the child's health outcome, particularly leading to unsuppressed viral load. Furthermore, effectively managing an adolescent with unsuppressed viral load, especially in cases involving non-disclosure and lack of responsible caregiving, requires a coordinated yet multi-sectoral approach. This approach could involve both healthcare facility and community-based support systems to ensure comprehensive care and improve treatment adherence. Questions for the experts. How can we address barriers of disclosure in adolescents living with HIV in the absence of parental, caregiver, or peer support? Thank you, and over.
Thank you very much, Mr. Onunguga, for that insightful and well-detailed presentation. Please want to welcome those coming in. Kindly share your question using the chat box. At this point, we'll invite our panel of experts to provide their perspective on the case presented. But before they come in, let me briefly introduce our distinguished panelists. First on our list is Professor Sir Augustine Omoigberale. Professor Augustine Omoigberale is a professor of pediatrics and child health at the University of Benin and an honorary consultant at the University of Benin Teaching Hospital. He's a fellow of the West African College of Physicians and holds a Doctor of Medicine from the National Postgraduate Medical College of Nigeria. He has received extensive local and international training, including at the University of Maryland and Baylor College of Medicine, USA. His expertise include neonatology, ventilatory support, lactation management, gastroenterology, and pediatric HIV/AIDS. With over 85 publications and supervision of more than 20 postgraduate dissertations, he has made significant contributions to research, training, and clinical practice. He has served as a consultant with WHO, UNICEF, PEPFAR, CDC, and FHI 360. He has held several leadership roles, including former president of the Pediatric Association of Nigeria and former chairman of the Faculty of Pediatrics, West African College of Physicians. He is currently a national clinical mentor for Delta State and remains actively involved in advancing pediatric and neonatal care in Nigeria. You're welcome, Professor Augustine. Please join me in welcoming Professor Sonny
Thank you very much.
Yeah. Please join me in welcoming Professor Sonny Ochibo. Professor Sonny Ochibo is a professor and an honorary chief consultant pediatrician at the University of Calabar and University of Calabar Teaching Hospital. He holds a postgraduate diploma in management and is the pioneer director of the Institute of Medical Sciences and Global Health, as well as head of neonatology unit. He previously served as head of the Department of Pediatrics from 2013 to 2015. He has over 20 years of experience in pediatric HIV care and PMTCT and has worked extensively with World Health Organization, UNICEF, PEPFAR, the Global Fund, and Federal Ministry of Health. He coordinated the PMTCT and pediatric program for APIN at Harvard School of Public Health for 6 years and has contributed significantly to the development of training materials, guidelines, and SOPs. He's a member of several national and technical bodies, including the National Task Team on ALT, Pediatric ALT Subcommittee, DSD Committee, and the Third Line ALV Committee. He's currently chairman of the Faculty of Pediatrics, West African College of Physicians, Nigeria chapter, and continue to contribute to research, teaching, and clinical practice. Thank you, Professor Sonny Otibu, for joining in.
Thank you very much, Dr. Helen. It's my pleasure being here.
Thank you, sir. So please join me also to welcome Dr. Mohamed Bello. Dr. Mohamed Bello is a health system professional with expertise in health financing, HMO development, and HIV program implementation in Adamawa State. As the HIV manager for the state, he has demonstrated commitment to strengthening vertical transmission prevention across health facilities, improving maternal and pediatric outcomes through strategic and system-focused intervention. He is passionate about building resilient healthcare systems and advancing sustainable health solutions. He is known for his leadership and strategic thinking and brings a practical, result-driven perspective on health system strengthening and program implementation. It's good to have you, Dr. Mohamed Bello, and to all our panelists just introduced. And we look forward to a rich and engaging discussion with practical insight grounded in real-world experience. So we would begin with
much. Thanks for having me.
Yeah. So we would begin with the panelists. Professor Augustine, what would we have done or the case presenter have done differently in the case presented? Thank you.
Am I being heard?
Yes.
Yeah.
Please go ahead.
Thank you very much, Eileen. Thank you for inviting me to this webinar. I am glad to be here. Now, taking the first case scenario, I think I have 15 minutes. I will comment on the first case scenario and also comment on the second case scenario. Or should I just take only the first case scenario?
You can go ahead.
So that my colleague and friend.
Oh, okay.
So that my colleague can comment on the second case scenario, all right? So that we share it equally. Now,
yeah, that's fine.
I think Michael did all he could have done, from that case. And we'll look at it, that first case scenario. The major problem was identification problem. Apparently, because of the way the lady came, they didn't identify that identification was a huge problem. Now, for such subsequently, what I would have done there, I'm going to mention this in about 5 or 6 categories very quickly. The major problem with that first case scenario was identification problem and bridging community gaps. That's what I saw in that first case scenario. So if I would have, if it was me, the first thing I would have done, since I now know that it was identification problem, is 1, to strengthen patient identification systems, especially in a situation where you don't have complete documentation. So I would have done what I would call flexible low barrier patient identification systems, ID systems. What I mean by this is, e.g., biometric identifiers. I would have done biometric identifiers if I identify the problem ab initio, and again give unique codes or a photo face records that do not necessarily rely on normal or formal documentation. 2, I will also have done standardized or promote standardized data capturing tools, which will include alternative identifiers such as phone numbers of relatives, even though they said they tried to get the phone number of the brother or husband, then landmarks and community contacts. Those things were not done in that first scenario. I will have done that. Then I will also have introduced digital health solutions. What I mean by digital health solutions, I'm talking of EMR, that is electronic medical records, and mobile apps to track, because tracking, incomplete documentation and tracking were the major problems in that first scenario. So that's under health, strengthening health patient identification system. Then the second point will be community-based tracking and linkage models. Under that, what I will have done is to partner with community healthcare workers, choose community healthcare extension workers, peer mothers, and mentor mothers to serve as trusted links between the facility and the patient. Then under that, I will also have recommended leverage on the local leaders, faith-based organization, and CSOs, to help locate and re-engage the client with no formal. I hope I'm still being heard.
Yes, sir,
okay.
You are.
Okay. So then thirdly, under that community-based tracking and linkage, I will also have done what I will refer to as community mapping strategies to identify informal settlements and high-risk populations. So those are the two major things. Then the third one will be policy advocacy and inclusive care models. What I mean by that, under that category, to advocate for non-discriminatory healthcare policies that allow undocumented or mobile individuals to access healthcare without fear or favor. What do I mean by that? When you have people crossing borders, either district or states or even countries, because of no adequate immigration immigration policy, they are afraid to seek healthcare so that they don't get repatriated. So I will advocate that and work with governments to decouple healthcare access from immigration or formal ID requirements. Then, of course, while doing that, I will encourage confidentiality protections to build trust among vulnerable population. Then the fourth thing I will do is to build capacity for healthcare workers. And that's where PATA comes in, building capacity for healthcare workers. This will entail trained healthcare providers on managing patients with incomplete documentation, managing patients with culturally sensitive communication, and develop techniques for collecting alternative tracing information. I'm sure PATA can play a role on the training of these health workers of what I have done. Then the last under that heading will be build skills in risk certification strategy to prioritize follow-up for high-risk patients, e.g. pregnant women with IT, just like this index case. Then the fifth item, enhance adherence and retention support Under that, I will now try to do the following: scale DSD, scale differentiated service delivery models. That is patient-centered care, DSD models. And this will include multi-month dispensing or and community AROT groups. Then provide targeted counseling, as Mike had said, addressing stigma, mobility, and cultural beliefs, especially letting them know that reliance on herbal medicine may not help. Then the sixth item, I will do that, cross-border and mobility awareness systems. Under this, I will facilitate inter-facility and cross-regional data sharing frameworks while maintaining privacy. I had already mentioned that. Then, of course, last not the least on that item is you support referral systems to allow patients to continue care seamlessly wherever they relocate. Because in the narrative of this patient, apparently, with the viral load suppressed, it occurs to me that this patient may have been getting services elsewhere apart from the particular area where he was diagnosed and started treatment. But I think the patient, because of either rejection or fear of not being accepted back to the original clinic, did not volunteer that information. Lastly, I will do innovation and pilot programs. We'll fund and test pilot programs like biometric patient tracking, mobile follow-up systems, SMS, WhatsApp. Then, of course, we will now scale up sensitive models across partner facilities. Now, the major item here, with those ones, I'm sure this patient, even though they still tried, they were just lucky that this patient was accessing care somewhere, even though he didn't volunteer it in that narrative. So these are the things the state government and the partners will do. I think I will lay emphasis on training of health workers to see some of these clients with undocumented or incomplete documentation, to do appropriate training of health workers to be able to work with these patients. Over. I hope I mentioned community engagement or community. Yes, I did. Elaine, over.
Yes, you did. Thank you. Thank you very much for that well captured highlight you made. The question I would want to ask Professor Ochibo from the case presentation or the case scenarios presented, what are the key missed opportunities? What are the key missed opportunities you saw, especially for the child whose father is a pastor and whose mom died of HIV, and he has relegated his duty to his neighbor, while, going about doing his pastoral ministry, not forgetting that his first role is to care for his immediate environs. Thank you.
Professor Sonny, I hope you are there. Okay. Did you hear what Eileen said? Professor Ochibo.
I think I partly heard her. She was breaking, but I've lost her now.
Okay. Are you back?
I was basically asking, what are the key missed opportunities that we have seen from these case scenarios presented, especially for a child who was infected with HIV through his mom, and his dad is a pastor, but relegated his duty to a neighbor while still pastoring. So what are the key opportunities from missed, and what lessons can we learn, especially from the second case presented? Kindly confirm if you can hear me.
We can hear you loud and clear.
Sonny, do you have any problem with internet?
Hello?
Do you have any problem with internet, Sonny? Are you back now?
Yeah, I'm here.
So what he's saying is saying for the second scenario.
Okay, second scenario.
Yes.
Okay,
He said
which is a 17-year-old.
Yes.
Okay, so let me.
The scenario said the father is a pastor, and yet there was no easy disclosure and all that. So he's asking you, what are the missed opportunities in that case scenario?
Okay, thank you very much. Yes, I can understand now. I really didn't hear her initially. So once again, I want to appreciate Pata for organizing this. This is a typically a 17-year-old boy who has gone through a lot of challenges as regards care. And this is also not new to a lot of our healthcare workers who see this kind of cases in their facilities. So what is outlined here that is clearly spelled out here is the fact that this adolescent, had, did not have the required or prerequisite parental care from the father who is a clergy, who is moving from one hospital, one church to the other. And we didn't hear much about the mom, but they said the mom died, and then the aunt was also, taking care. We also, realized that there was denial initially in this patient and then the parent. And what also stood out in this case scenario is the fact that this child was not disclosed to. And for a 17-year-old not to be disclosed to at this material time also shows that there will be non-adherence to the drugs. So one is not surprised that the CD4 count went as low as below 200 cells per millimeter cube. And with this CD4 count cell that is less than 200, just shows that this patient has advanced HIV disease, okay? And then with advanced HIV disease, there is also important for us to look beyond TB, because from the case scenario, we realized that the clinicians were targeting TB. And unfortunately, all the tests they did for TB were negative. Apparently, the child still had persistent cough and candidiasis. So what is the lesson here? That beyond TB, there could be some other infections that can cause cough. And therefore, one should always look out for TB and other infections of the chest. So now we need to exclude the possibility of PCP or PJP, pneumocystic jirovecii pneumonia. Yes, it may be difficult to make the diagnosis because the test that is required for such diagnosis to be made may involve invasive investigations. However, the clinical examination will also help. In the absence of a TB and a patient who has CD4 count less than 200, therefore, such patients should be, high index of suspicion should be high for the diagnosis of PJP. In addition to that, lymphocytic interstitial pneumonia is another differential, which should also be excluded from this patient who has persistent cough as well as candidiasis. Hence, from the history, we were not told about the SpO2 of this patient. If we had an indication of the SpO2, because patients with LIP tend to have very low SpO2, and therefore that would have also helped us in making a diagnosis, as well as the electrolyte urea and creatinine, focusing more on the bicarbonate level. So that also will help us. So beyond the bacterial infection, for such patients, you may be thinking of other fungal infections as a cause of pneumonia in these patients. So what we also like to know about this patient is the fact that the patient should have had co-trimoxazole prophylaxis. So in addition to this case scenario, so clearly it just stands out that this disclosure was an issue, and you know that disclosure is not something you do as an emergency. It has to be supported, and then patients need to be informed, and they disclose, in gradually to such patients. But for this case scenario, whereby the parents are not there, the aunt is not always there, so the doctor is supposed to support the process of disclosure. But if the aunt is not there and this boy has come of age and the parents are not in a position to disclose, the doctor may at this point in time disclose to this patient, more so because of this situation we find ourselves. So the disclosure process must be taken seriously in this patient so as to achieve sustained adherence. So the other thing we need to do for this patient is the fact that this patient, though it was given the OTC services, should also be sustained for this patient. Now we have to look back. What are the support services that this child had or is having beyond the fact that he needs the education? Where is he living? What does he eat? What's the food security like, and the rest? And how, care, even though the parents are moving around, the father, what kind of care is he really receiving at the end of the day? Those are some of the few things that we need to look out for as one of the missed opportunity. The other thing one needs to think closely, about, especially as regards PATA, and how do we support our healthcare workers to have the capacity to disclose, is that we need to train our healthcare workers on the different processes of disclosure, the barriers to disclosure, and how disclosure should be made. And just to let you know that we have documents, we have manual for disclosure in the country, which has been made available. Okay, so, and it is expected that PATA on her part should see how they can train healthcare workers on the process of disclosure, because I know truly well that some of these cases still exist, and a lot more will come because of the lack of we do not really embrace the culture of disclosing to our patients, our children early in this country. So these are some of the missed opportunities, and that we need to really hammer on, so that at the end of the day, adherence will be good. So early disclosure processes is important, and that should be done by parents and supported by the healthcare provider until the patient has a full disclosure. So as regards the case, the other missed opportunity is the fact that beyond TB, we should also look for other infections that affect the lungs, that affect the respiratory system, and which could be the pneumocystic girovecin pneumonia, LIP as well, which was not clearly excluded in these patients. And also the need for co-trimoxazole prophylaxis for this patient, especially this patient that has CD4 count less than 200. So by and large, I think these are some of the few opportunities that the patients need to have. But I think I may stop here for now, except maybe during the course of question and answers, and if there are other questions that come up, we may respond. So thank you very much for your time. Over.
Thank you. Thank you very much, Professor Achibo, for that information and the clinical experts you've just highlighted. In terms of cotrimoxazole, there's a need for children to be placed on cotrimoxazole because it has been shown to help in terms of upper and lower respiratory tract, and it's also good in terms of protecting the brain, starting from the brain, to the respiratory tract. So our healthcare workers, it's important that we push for Cotrim availability and implementation of Cotrim, in our facilities. So the SAPC, Dr. Mohammed, how ready are we in terms of what are the practical steps, TA partners, IPs, and facilities? What are the practical steps from these case scenarios do you think we can implement immediately?
Yeah. Okay, thank you very much, and thank you for the opportunity to speak at this moment. And I want to write on what our two professors have said and to dissect the two cases differently. For the first case scenario underscores that issue of interruption in treatment over a long period of time is the major issue in the first case scenario. And this has just clearly indicated that the system is having some weaknesses in terms of identifying patients who defaulted and to the extent of running into IIT. We need to put in place within the facilities defaulter tracking mechanism, particularly for women, for pregnant women, and for children. This is to avert this issue of long-term interruption in treatment and for patients and children to run into IIT. I think what is missing from the system, from my own understanding, is that there is no defaulter tracking mechanism in that facility. Otherwise, it wouldn't have taken that long without identifying this particular patient. Secondly, there is also a weak link between the facility and the community, as also emphasized by Prof. We need to strengthen the link between the facility and then the community. This is to ensure that anytime a patient missed appointment in the facility and his contact is not reaching out, and then also we should have somebody in the community who knows the whereabouts of that particular patient or that particular client in question. And also we need to strengthen collaboration between the civil service, civil society organization at the community level and what we do in the facility. This will go a long way in helping in identification of clients who miss their own appointments. And lastly, I want to say that the case management system in that particular facility is also weak to some certain extent. That how can we miss a particular patient for even a month? We need to be having frequent contacts with the client so that the client cannot go into IIT. And finally, I can say that for every pregnant woman, we need to link them with a network of people living with HIV and AIDS and the ASH1. This will also help in tracing them should in case they did not come to the facility. I think this is my contribution for the first case scenario. For the second case scenario, as presented, the scenario highlighted that the child lacks structural support system. And also, the case further indicated that there is delay in disclosure that contributed to non-adherence and that led to the increase in the viral load. And also, the case further demonstrated how community EAC home visits can also help in strengthening adherence. So in all this, I am recommending that facilities and facility implementation IP and also the community implementation IP to work together, particularly in issues that has to do with children and adolescents. Because while we do the facility level activity, the community interventions also go a long way in helping to ensure that adherence to medication, adherence to instructions are duly followed. And again, at our own facilities, we need to strengthen and expand the OTZ clubs because children at that, adolescents at that age, they find it more comfortable to be within the mix of their own mates. Despite the fact that this particular client is a special one, they don't have a stable father, the mother died. So having a very strong OTZ club within the facility can also help. And we also need to integrate mental health and psychosocial support services into adolescent care. I think that is also another area that we need to do within the facility management. And again, for the issues of the disclosure, we need to train our healthcare workers, just like what Prof said, on age-appropriate disclosure counseling, because it is evident from our facilities that this is one of the major issues that are missing. Even the adherence counselor, they don't normally lay hands and they don't normally take time to read all the protocols and then the guidelines. And I think lastly, for that particular client who is a very special client, whose father is always on transit and does not have, even nutrition support, the father monetize, money for feeding for that particular child. That particular child needs to be linked to, some organizations for nutritional support, and there is also need for wider collaboration with other social protection programs that supports vulnerable households and vulnerable individuals. I think that is my own contribution. Thank you for the opportunity to be waiting for response and questions.
Thank you, Dr. Mohammed. At this point, are there questions? So the floor is open for questions and reflections from the participants. Please share your questions in the chat box, or you can raise your hand if you want to speak. So around Professor Augustine spoke about differentiated service delivery, bridging the gaps between the community and the facility, strengthening referral system strengthening. As a key stakeholder, Professor Ochibo, in the DSD domain, how ready are we as a country in decentralizing the service delivery to pregnant women, and children at the community? What's the policy in terms of guidance and policy in terms of DSD at the community for pregnant women and children, knowing the peculiarity of pregnant women in terms of focused ANC care and children under 5? So where are we in terms of DSD for these pregnant women and children at the community?
Okay, thank you very much for the question. Well, as you all know, that DSD is an important integral part of our health system, and which is patient-centered. And you all know that one of the reasons for DSD is to decongest the healthcare facility, as well as give the patients the best care of services without stressing them over time, and taking the services closer to to their domain, and while not reducing the quality. Now, we have some peculiarities which has to do with children, especially children who are less than 5 years, as well as the pregnant women. Now, for the children who are less than 5 years, because of this peculiarity and the fact that the changes in weight occurs, and then the fact that patients or parents may not know some of those very subtle changes that takes place in children, which may be difficult for them to identify except the healthcare provider. So we advocate that such children should not, undergo the process of DSD. However, those who are beyond 5 years, they can have, structured DSD, which has to, in addition to the DSD, they also have the opportunity to have MMD. And we advocate primarily for those who are less than 10 years to, if they are going for MMD as part of the DSD, is to go for not more than 3 months. After 10 years, yes, you can now begin to move them to between 3 to 6 months. However, once these patients are already on DSD, they must be regularly monitored by a facility very close to them. And you also want to determine the type of DSD that such patients should be involved in, depending on what is available in the community and the reach of these children. But however, these are the primary overarching subset of the DSD. So for the pregnant women, the teaching is that this is a very mobile group, and usually within the first trimester and the second trimester, one has to be very careful with the DSD in some of them, because a lot of things, events might happen within the 9 months period of pregnancy. So put them on DSD because we need to monitor this the pregnant women. However, if there are facilities within the hub and spoke model in their community, yes, such patients can be monitored, but not clearly distinguished into DSD. I think for more details, we can look at the manual and see the various models of the DSD, whether a facility DSD model or a community DSD model. And for each community, not one system fits all. We depend on what is available within the community and what is doable within that community. Are we using the medicine vendors? Are you using the healthcare provider system? So this has to be evaluated by the healthcare provider to determine which the best of the DSD that needs to be given to such clients. Over.
Thank you, Prof.
Hello.
So, yes, thank you, Prof. So it's important that because we wanted to be sure where we are in terms of the policy and DSD. Do we go ahead as TA partners to the state, working with the implementing partners to start bringing up DSD at the community? So there's now a caveat. Children under 5 won't be devolved into the community, and children under 10 would be devolved, but at the facility level. Is that what you are saying?
Yes, they can be devolved. Even those who are more than between 5 and 10 years can also be devolved in the community level, but not going beyond 6 months of MMD. They usually we want them to have 3 months MMD. The reason for this is that for us is to enable us monitor them. But those who are beyond 10 years, yes, they can have the leverage to go between 3 months and 6 months. Then 5 to 10 years, usually not more than 3 months of MMD. But more than 10 years, you can go between 3 to 6 months, depending on the situation you find as a healthcare provider. And these are for obvious reasons, because we don't want to leave our children who are still under 10 years for 6 months without attending to them. So even if we're going to give leverage for DSD, yes, 3 months is still okay for those who are less than 10 years, between 5 and 10. Over.
So yes, thank you. So this is for Dr. Mohammed. While we await questions in the chat box, um, how ready is the state in terms of DSD? How ready and where are we in terms of decentralizing service delivery for pregnant women and children in Adamawa State? Where are we in terms of DSD implementation?
Okay, thank you very much. Adamawa State is one of the few states that benefited from the ICAP project previously, where the DSD...
Please, Dr. Mohammed, can you increase the volume? Can you speak a little bit louder? Thank you.
Okay, I say in terms of DSD implementation, yes, in terms of DSD implementation in Adamawa State, I can clearly say that Adamawa State is one of the few states that benefited from the ICAP project previously on DSD, where the DSD operational manual is being tested here within some of our facilities, and also the quality of care on DSD was also piloted across some few facilities. And since then, the level of knowledge of our healthcare workers is increased on DSD, and development of stable clients took effect since 2023. I can say currently that all DSD implementation in Adamawa State is fair and very, very optimal, but with emphasis on those clients who are stable. And also, we also use several DSD methods like fast track, and all of that is being implemented in Adamawa State.
Okay, thank you very much. Please, I have to come in to appeal that we have seen a lot of cases, not peculiar to Adamawa alone, in some facilities that we see, in country, a lot of our children are placed inadvertently on 6 months DSD. And that, will result into them having very high viral load, inconsistent results, both the CD4 and viral load. And by the time some of them come around, they are down with one ailment or the other, which was initially not identified. Because children will not really tell you what are the issues, and some of those illnesses are subtle. That's why we try to put caveats onto the duration whereby they have intervention or contact with the doctor. So I will appeal that you strictly look out for these children who are more than 5 years, but less than 10 years, to be on 3 months, not beyond that, so that we can monitor them, very well, knowing fully well that if the adherence is poor and they fail, doing a resistant test is challenging, and they don't have the latitude for numerous drugs like the adults have. So we are very cautious with that. So if you monitor what MMD they are following in the course of the DSD, with depending on the age disaggregation, will be well appreciated. Thank you and well done. I hope I was heard.
Yes, thank you. Thank you
Thank
for that. So the important thing is to be cautious about the DSD, the MMD placed on children, and it's important to closely observe these children. you know, our
Can
focus
I
should be really, yeah.
also make a comment about the DSD?
Yes, please.
Now, my colleague Sonny said, and Mohammed, you see, before you embark on DSD, you have to have dedicated care workers, especially for children less than 10 years. Part of the DSD program you want to do for them is to vary their clinic attendance. You know, for instance, in Delta State, what we're doing that time is, children go to school in the morning. They may not be able to come with their mothers to access drug and all that. So part of the DSD we did, available for healthcare workers who are dedicated to their job, is to arrange in such a way that they are seen when they come for clinic, either drug refill and all that, after their classroom. And as example, they go to school in the morning, so they won't be there. So the head workers have to be specially dedicated, to see these children and the doctors around 2 p.m. to 3 p.m. when they will have finished from school. That is those that are doing at the clinic level. And it's very important so that their clinic attendance will be almost 100%. It is part an aspect of DSD that is very crucial. But like Sonny Ochibo said, these health workers, whether it's in Delta State, whether it's in fact, all over the country, it's just that you are only operating in Delta State and Adamawa now. But even within Delta State, we still need to reinforce it and do some training to tell them about the various aspects of DSD. Even those DSD that is attached to the hospital, how you can make the clinic attendants malleable to suit the child and the caregiver. So I just thought I should add that. Thank you. Over.
Thank you very much, Prof. And I think this is well noted. And we are here in Adamawa State for children and for clients who are not stable. We even have some dedicated, healthcare workers. There is healthcare. The management system is in such a way that there are professional case managers who manage them, and they are specifically trained on all these guidelines to ensure that children are not just devolved, but they see clinicians as at when due. And there is no way a child less than 10 years can even be devolved onto DSD. DSD is mostly applied to adults who are stable and who is even suppressed to the extent that he needs less clinic visits. This is to decongest the ART clinics. Thank you, and over.
Yes, thank you for all your contributions. So presently I'm on the chat box and I would like to read out some recommendations from our participants. So we have a comment from Amina Haja Hamina Mohammed. She said, I would like to add on the second case of the adolescent that we should also integrate and link these adolescents to career guidance, career guidance and skill acquisition. Another comment made from Haja Amina Mohammed is, as part of DSD for the child in Adamawa State, the state usually provides after school hours and weekend services. That's a good one. We have another comment from Rumbizia Vavengia. Kindly tell us where you are commenting from. He said or she said, children gain weight fast, so they should not be given more than 3 mmD because they end up underdosed, exposing them to high viral load and opportunistic infection. A comment from Tabisha, the country lead for PATA in South Africa, said South Africa has a project of giving treatment to children during the school holidays, which happens every quarter, that helps with DSD. Thank you all so much for your contributions.
Okay, so I want to thank all the contributors for very, very useful contributions. Number one is that the skill acquisition and guidance counseling is key. And just to let you know also that it is not only meant for the HIV positive children, it's meant for both HIV positive children and negative children, even adolescents, because that's the way to go. We get a quick skill acquisition, and so that at the end of the day, they have something they can fall back to when it has to do with some support services and IGR. The second comment, well, I completely agree with that, and that's what we have always said: the 3 months DSD for children. In fact, currently, I am reviewing a data where I saw some children and adolescents both were haphazardly put on 3 MMD and 6 months MMD. I've looked at their viral loads separately over years, and very soon I'm going to give a report on that. One of the outcome is that those who had 6 months tend to have better retention, but those who had 3 months had better viral load suppression. So I'm still working on that, and at the end of the day, I'll make it public for healthcare workers to look at and then, study so that it can guide us on our decisions subsequently. Over. Thank you.
Yeah, thank you. Any questions? Comments? Before we call it a day? So I would just want to highlight a few key takeaways from today's session from the panelists, and we'll take it back as a lesson learned as we go ahead with our implementation. One of the key highlights before we call it a day is centered care, builds trust and retention. From the first presenter, Dr. Moemeka, it's noticed that establishing strong relationship between healthcare providers and clients fosters trust, improves communication, and supports long-term retention in care, even among highly mobile population. She was lost to follow up. She came back after 5 years, but because of that strong relationship encountered in that facility between herself and the healthcare providers, she became virally suppressed. It's also important that we take back that community and partner engagement remains an underutilized opportunities. So as PATA, we'll be working closely with the implementing partners, the states and experts, to ensure that we strengthen community linkage, because it's important that we strengthen this community linkage. From the first presenter, Dr. Moemeka, we noticed that limited partner involvement and weak community linkage were missed opportunities, which enabled the loss to follow up for 5 years. 5 years is a long time. So we'll be working closely with the states in strengthening index testing, strengthening community-based follow-up. At the end, we hope that, community intervention will be significantly improved. Another take-home, from this presentation is integrating service delivery. It's important that we integrate service delivery. The successes achieved from the first presentation is that the case was driven by a comprehensive approach. They combined ANC, HIV treatment, EID, immunization, and psychosocial support, which ensured continuity of care for both the mother and the child. For the second presentation, it's important that we enhance, we engagement saves outcome, even in high risk, in high risk cases. You know, it's important that we create an enabling environment. I think we need to, as a TA partner, we need to revitalize the provider care initiative that we had during the OVC project, the Lopin 3 OVC project, whereby we called in caregivers of these children and trained them. So we'll be looking at that, and this was highlighted by the professors. So these are just um, um, few highlights or few key takeaways from today's presentation, and we hope that in the next session, all these gaps noticed would be closed. It's also important to note that this session reinforces that with the right system, patient-centered approaches, and continuous engagement, we can achieve zero transmission even in the most challenging circumstances. We encourage all patients, all participants, to reflect on how these lessons can be applied in our respective facilities. It's important to note that small, consistent improvements in practice can significantly reduce vertical transmission and improve outcomes for pregnant women, children, and adolescents. Our next session will be sometime in July, which will be shared across all designated platforms. I would encourage every one of us to join the PATA Learning Network and the Flash Friday, which is a WhatsApp linking and learning platform, where we have 10 minutes looking at guidelines from various countries from WHO. It's important you join the Flash Friday. I would like to sincerely appreciate our case presenters, panelists, and all participants for your valuable contributions and engagement. Thank you very much, and see you shortly.
Thank you very much.
Thank you very much for
Thank you.
giving us the opportunity to contribute our expertise and knowledge. And I will tell you, we thoroughly enjoyed this session. I hope some of the takeaways include training, like Chibo suggested, whether in Adamawa or in Delta. Some of those head workers will still need training. For continuous performance, training and retraining is very, very important. That's my last comment. Over. Thank you for giving us opportunity.
Thank you very much.
Thank you.
Okay. All right.
So
Thank you very much.
We will take that. We should also note that due to the dwindling of funds, yes, we would have our trainings. Trainings will be held, but it will be in a hybrid format. We might not be able to accommodate all healthcare workers, but we would see how we can make an effective training, capacity building for these healthcare workers, especially in terms of disclosure.
Thank you very much, Dr. Ali. That is key.
Yeah.
That is very key. We don't expect everybody to be there. There is what we call step-down training. So those who are given the capacity will get back to their facility and do the step down. So I want to appreciate Pata for giving this opportunity. I just have some few take-home points for my healthcare workers at the facility. One is to support age-appropriate disclosure early enough so that the issues of adherence and paraload anomalies would not arise. Then importantly, I want to say here that all cough is not TB. Therefore, beyond TB, look for other causes of cough. We had a very good example of this. And then we need to sustain our OTC program, especially for adolescents. And never forget the co-trimoxazole prophylaxis. It's very key. It sounds ordinary, it sounds easy, but it's important for the care of HIV patients. And I want to also appreciate the suggestion by one of our participants who talked about mental health integration. It is very, very important, especially among the adolescents who inadvertently get to know about their HIV status without following the process of disclosure. It can be very, very serious program and serious issue which can affect the psyche of any individual. And then lastly, sustain continuous engagement and follow-up of our patients. I use this opportunity to appreciate Pata and thank every one of you for coming. And I want to thank my boss also, Professor Austin Obokberale, for being there. Thank you. Over.
Thank you. And over. So before we call it a day, I just want to read this from Igwe Kelvin. He said, while stigmatization and discrimination remains challenging in the two scenarios presented, there is justification for implementing the proposed policy, Bill on Stigma and Discrimination. Where such a policy exists, mechanisms should be established to strengthen it without infringing on the human rights of clients, consumers of care. Amina said we also have a caregivers forum to discuss disclosure issues. So so for the policy, I know for in terms of bill on stigma and discrimination, but is this policy, is it in use? Has anyone been charged for stigma and discrimination? Have people been trained on it? And the repercussion, have people been called out or have people been sent to jail for stigmatizing? So these are the issues. It's not about having policy documents, it's about enforcing those policies to reality. And Hadia Amina, yes, in terms of the caregivers forum, we would be working with implementing partners to strengthen this caregivers forum, to reactivate it or to reinforce the caregivers forum and see the needs where we have more participation, active participation in this forum. Yeah. So thank you once again. Thank you all for joining, and we'll see you shortly in July, God's willing. Thank you, and over.
Okay, thank you, and do have a nice day.